organization, but the process I'm going to talk about in particular is how we do our daily management at our community-based hospital. What if it was your daughter, your spouse, your loved one? I want to talk to you about the vision phrase of GBMC because it's an important factor of how we tie that into our daily management work. Our vision to every patient, every time, we will provide the care that we would want for our own loved ones. In your systems, when you're working and you're observing what's happening around you, is it good enough for how you would want your loved one to experience their health care? So how do we know? How do we work towards that vision, that ideal, that goal? Well, we follow our quadruple aim. This is going to sound a little bit familiar to folks here at IHI, but we're focused on better health outcomes, the best care experience. We interpret the next one as least waste. We're looking at both cost and inefficiencies in our system, the best flow possible. And then we also have a fourth aim, which is most joy for those providing the care in the system. And you're going to see how we tie that into our lean daily management process. Our lean journey begins in 2010 at GBMC, and it starts at a place that probably most of you have started in. Some overall employee education, maybe defining what waste is in the system and conducting some waste walks for people, and also a series of rapid cycle improvement events. These Kaizen activities at GBMC, for the most part, were 4.5-day events, and we brought together groups, interdisciplinary groups, to work on a process, a system that we knew needed improvement. We provided them just-in-time training on the lean tools that they would be using. And then they would put them immediately into action. And by the end of that week, they would do some tests of change on their way to improvement. And throughout that process, our executive team was also engaged, coming to our daily report outs and playing a great role in both encouraging and removing barriers on our way to achieving success. So I think, like Richard showed earlier in one of the slides, we had some great results, some incredible excitement from this PI activity, but we'd start to see some fragmentation over time. But the other thing that we noticed is our culture wasn't really evolving to one of continuous improvement. That perhaps we may have sent the message that improvement was a one-time or sometime event that people were invited into to participate. They'd leave really proud of their accomplishments, high fives, saying how much fun that was, and hey, let me know if you need any help for a future improvement project. I'm going back to my regular job now. So we needed to figure out how do we sustain our improvement, but how do we really tap into that cultural change, that shift that we wanted to see happen at GBMC. We also noticed that not all of the people that were trained necessarily felt like they were masters of the tools from being in these events. So we also knew that we had to create a tool set that they felt comfortable with engaging their staff. So we begin a journey of lean daily management in 2013. What is lean daily management for us? Well, that is a daily disciplined process of managing your metrics, looking at your improvement, studying it, learning from it, creating tests of change and doing some performance improvement as a result of it, and really creating a culture of people across the organization, frontline managers, executives that are engaged every day in performance improvement. Our goals for LDM were that cultural change, but it was also that frontline engagement piece. We wanted them to know that they had the power. They're the ones that are doing this work on a daily basis. We need them helping us redesign our systems of care. They have a voice. We need to show them, we need to empower them to use that voice. We knew we needed to design a system where managers were accountable for helping their staff and engaging them in these improvement opportunities, but we also needed to give them tools that were easy to understand, that they felt competent in sharing with their team, whether that was a 5 why activity trying to understand the root cause of a problem, whether that was the way our LDM metric board was set up so that they could see the why we were missing over and over again and direct and focus their improvement activity, or if it was using model for improvement to do their small test of change on their way to transforming the systems of care. And finally, we knew we didn't want to leave the executives out because that was powerful during our Kaizen activity. So we wanted our executives to participate in this as coaches and mentors, but also as barrier busters that can help us kind of take that leap a little more quickly, but also make sure that what everybody is focused on still has that connection to our aims and our overall vision. So, who participates in LDM? You're seeing a picture right now of one of our inpatient units at GBMC, and this is an inpatient unit that happens to be run also by our resident team that provides care. And, in the picture you see our nurse manager and our director and 2 residents, and if we were to pull back a little bit, you would see probably some frontline nurses there as well as the executive team receiving a report on the board. There's information, most boards contain 4 metrics. All 4 of them are tied to our quadruple aim. What you also see on our board is lots of red, and that's by design. And that can be a little scary, because that's a change. We want, when they pick a new metric, we want them focused on the problems. This isn't an exercise in patting people on the back for achieving green and picking things that we just celebrate all the time. This is an exercise in transparency, posting the items that we need to do the most work on in a very visible location in these departments. These are not hidden in like lunchrooms in the back corner. These are places where people can collaborate, huddle around, work together to improve these problems. So we want that engagement of staff, and we want the board to reflect when there is evidence of problem solving. What does our walk look like, our LDM walk? Well, we start at 9 a.m. every day with an executive team huddle. Our executives have a series of metrics that they're studying and keeping their eye on. I can tell you that 2 that have been consistent from the beginning of time are both incidents of patient harm and employee injuries. We never take our eye off of those, and we're constantly studying and learning and improving our systems around that. After that huddle and that relay of information, our teams divide, and right now we have 5 different routes that they'll visit. So we have 2 to 3 executives per route, and they'll go on that same route for 2 weeks, which should be enough time for them to see some evidence of problem solving and get a sense of what those departments are working on. The department presents their LDM board, and it's very structured. We're there for 5 minutes at every board, and that's all. And the department is talking about what happened yesterday. Did they meet their goal or not? If they didn't meet their goal, why? What happened? What was the reason? There's a reflection on what did they learn from studying what happened yesterday? And there's also a discussion about what problem solving, where they are in the problem solving process for each of these 4 metrics. The executives then relay information from the executive board about those executive level metrics. And then there's a discussion. Are there any barriers in your way of achieving your goal today? Are there any safety concerns that you need our help removing for you? Equipment needs, anything like that that the executives can help push along. Following that, everybody meets again in the executive office for a post-walk huddle, where we assign those barriers that may have come up during the walk to the appropriate person. And we also talk about those examples, those positive examples that are happening in the practice. And finally, there's an opportunity to learn and to share the learning. There's an email that goes out every day after our walk that communicates to all of the staff at GBMC about what the learning is, particularly around those executive level metrics. And a tip, a Tuesday pearl that is communicated of what we would like people to know, particularly around the incidents of harm. We do our LDM 365 days a year. I don't know about your hospital, but we're open every day of the week. And so we know that it's important that we're sending a message that this just isn't a Monday through Friday, 9 to 5 kind of gig that we're concerned about. We're concerned about this culture of improvement and making sure that everybody knows we're serious about it throughout all of the shifts, every day of the week, even on the holidays. So our administrator on call will come and walk all of the boards every holiday and every weekend. I also wanted to note that the folks who participate in LDM, this isn't just a clinical focused activity, although they're certainly all on board. All of our inpatients are on our LDM walk. All of our surgical areas participate, but we also recognize that we needed those support areas involved too in doing that problem solving. So places like pharmacy, rehab medicine, environmental services, transport, we visit all of those support areas and support them in doing the problem solving. And so a word about the executive level engagement as well, because this is a big commitment, right? We have this no-fly zone on their calendars from 9 to 10 every day, Monday through Friday. And we're asking them, if they're here, they need to be present at the walk and not just, show up, but be present at the board, no cell phones, no sidebars. This is intimidating stuff. Asking somebody that might be a unit secretary to present a metric to the CEO that arrives in a suit and something's red and they're going to explain what happened. So we need to develop that trust, and that takes some time. So our primary role, especially when we first go out there, is saying thank you, providing words of encouragement, and also using Jay Collins' The Art of Humble Inquiry, providing coaching using inquiry, asking questions. Oh, that's hard to do. It's so tempting to I know what you need to do, you should try. But that doesn't help people become great problem solvers in their own. So ask the right questions, create a supportive environment, and that's how we get through this process. So our results, I've got a lot of results up here on the board. The graph, if you can't quite read it, is talking about the improvement that we've made since going live in LDM on serious safety events. I guess I wanted to use one example in particular. When we started this, we were looking at our pressure ulcers and our serious pressure ulcers, and I think the slide says we've gone over 3 years without a serious pressure ulcer. It's actually close to 4 right now. We're almost at that 4-year mark. And we did this not just because the executives were focused on that metric on LDM, but because we had partners that were working on this at the inpatient areas. So we had nurses that we quickly realized on that metric when we put it out. We were looking at anybody that had a high-risk score where all of the safety interventions in place. And we found we were pretty good at most of them and might have had to do a little polishing on some, except for that turn every 2 hours. Oh my goodness, that was a tough one to make sure that we were doing accurately and correctly and consistently. But through having a team of people that were engaged, it wasn't just, okay, well, you're the nurse, you gotta remember every 2 hours, don't forget, because that's not designing the right system of care. It was, how do we come up with a game plan first thing in the morning between our nurse and our techs of who's gonna do what on what shifts? Maybe during medication administration times, we have to ask our tech to be the person that's doing that. But we come up with that schedule first thing at shift changeover. That's part of the learning that we've created in this LDM process. So as a result of this, I'm pleased to say we were just down in Orlando in September. We received the inaugural Patient Safety Award from the Ashram Conference for our connection of this daily management process and overall patient safety and quality metric improvement. A couple of lessons that we learned along the way. We need a quick win. When we have a new person that enrolls on the LDM process, we want them to select their own metrics. We don't want this to be top-down driven. So we want them to pick the 4 things that they have some interest and motivation around and are willing to roll up their sleeves and get to work on problem solving. But we want to be cautious that they're not picking the most difficult thing right out of the bat that requires collaboration with other departments. See, the thing is, they got to get good at problem solving first, internally. So one of the things we try to help steer them to is when they're first selecting metrics to put up on the board, select those things that that department has control over redesigning. And then you'll get to the point, we are in most of our locations, you get to the point where once they feel comfortable doing problem solving, right, then the next hurdle is how do you collaborate with other people together to do problem solving? That's LDM 2.0, but you get there. I talked a little bit about trust earlier, and that takes time to build, and part of the way that we reinforce that is that the focus isn't on people, it's on process. This isn't a gotcha exercise when there's red on the board, that we've got to approach it in the way that I don't want to see names on the board. I don't want to see on their Pareto chart that the reason they missed is, well, Dr. So-and-so came in late again, and that's why we didn't start that surgery on time. We want to talk about what are the things in the process that aren't working, that are failing, that we need to redesign. And I just wanted to shout out one other thing, that when we started this, we didn't design it with this in mind, but this broke down some barriers, first between frontline workers and executive teams. So we saw an improvement on our Prescani scores when we're looking at employee engagement, and those scores in trusted senior leadership. We've seen an improvement of that going up because our leaders and our frontline workers, they know each other by first name now. They have a daily opportunity to engage with each other. And the second thing is our executive team bonding, which was one of those things we weren't expecting. They see each other every day at 9. They're working with each other. We shake up the little executive teams every now and then so that they have an opportunity to do this walk with each other and get to learn from each other, mentoring and coaching tips. So with that said, that was a short period of time to talk about a lot of things, but I just wanted to extend an offer that if anybody would like to see it in person, please reach out and get in contact. We'd love to have you come visit us at GBMC and meet with some of our senior leaders and show you the work that we're very proud of doing. So with that being said, I'm going to turn it over to Jeff now from IHI, who's going to talk about testing the model.